Hi everyone, my name is Majala and welcome to the Sit Down with Majala.
Hey.
And today I've come with my very first guest, Miss...
Hey, I am
Sorry.
Mrs.
Dr. Swabra here.
Yes.
Please introduce yourself.
Hi, my name is Dr. Swabra Swaleh, a gynecologist based in Mombasa and also a mother. Yeah, clearly I'm being called mom. Yeah.
Yeah, so
Tuanze wapi?
I don't know, but I had posted on my stories last week, part one, that I would have a sit down with you, and I wanted people to ask questions concerning female reproductive system health and everything.
Woman.
Yeah, everything involving it. And I got a couple of questions, and those are the questions we are going to get into now.
Immediately.
Do you want the heavy stuff or the light stuff first?
You know what? Peak. Me, I'm ready.
Okay. Sawa.
Yeah.
First question.
Yeah.
When do you know, someone asks, when do you know that your period pain is not in the normal scale of period pain? Like, is this pain normal pain, or is it the one that I'm supposed to go and see a gynecologist? Like, how do you diagnose yourself and say, okay, I need to go and see a doctor? Yeah.
Okay. So period pain, first of all, is called dysmenorrhea as a medical diagnosis. And I usually want to first start by clarifying that period, well, it can be painless. It has a certain discomfort to it because the mechanism of having a period is your uterus is contracting a layer out. So of course, there's a level of discomfort. But the minute we say pain, the minute you associate your period with actual pain, now that's hapo tuko kwa shida kidogo, okay? And so usually we can classify the pain on a scale, 0 being absolutely no pain, 10 being the worst pain you've ever felt.
Yeah.
So usually I say anything you've ever felt that was really that bad. Childbirth, you felt like you're dying, that is a 10. If anything scores beyond a 3, that is notable pain that should be addressed and talked about. Or I find the simpler way being, if any discomfort takes away from your quality of life, then that is something worthwhile, worth checking out.
Yeah, because I used to see people, even in high school, some people used to pass out when they're on their period every month. They're passing out, they're vomiting, like they're literally very sick.
So you're either going to the ilikuwa inaitwaje tukiwa high school? Sunny?
Sick bay
or something.
I don't know. Yeah.
So if that takes away from class, if you have to go home, if you have to skip classes, if you are a working woman and you have to assess that, during my period, this is what I'm doing. Or if you, for example, have to schedule your gym around your period, just as long as you're moving your life around your period, then it's notable.
Okay.
Yeah.
Sawa. Next question.
Yes.
Bartholin cysts. What are Bartholin cysts?
Injectors.
Where do they come? What do they look like? What are those?
Oh my God.
Me, I had to go on TikTok to start like Googling, what is this? I've never heard of it.
Can we have a whole sex class today? Because, So, Bartholin cysts are your injectors. By injectors, I mean they are your lubricants, okay? Every time you're sexually aroused, your vaginal needs lubrication. And so that water, that fluid comes from a certain gland. And it's right outside. You know where your labia minora comes to meet that final V down. It has a very pretty name. It's called a fauché. It's a French name. Fauché. So anyway, so on either side of a fauché, then we have a Bartholin cyst. And most of the time, what happens is when you're sexually aroused, usually they will produce, and then they have like a canal, a pipe that now releases into the entrance of what would be your vaginal canal.
So,
pause.
I have one serious question.
Yes.
Is that like, okay.
What gets you wet?
No, not that. But I hear some women squat. Is that where the squat comes from? Oh, okay, carry on. Sorry.
Don't even get me started on squatting.
You're very passionate about it.
I put up a TikTok and Ugandans nearly killed me, but fine.
Okay.
So that is what gives you the lubrication during excitation. Now, it is important to note that a woman doesn't get wet inside the vagina. She gets wet outside the vagina.
Wow.
And the whole point of foreplay is to get this wetness that is outside into the canal that is the vagina.
Why did I think it was the opposite?
I know. There is nothing in the vagina there that releases fluid to get you wet.
Oh.
And so this plays a lot into stimulation and foreplay and just our sexual dynamics. Because, sorry to say, but men are lazy beings. They will twiddle a little, on the nipples here and there, whatever they do. And then they'll touch quickly and then they'll say, she's wet. It's just the Bartholins that have released, but your wetness haijaingia ndani. So the whole point of foreplay is to serially introduce this fluid, slowly up to all the way in. So even during, sorry to say, your audience are grown women, even during the actual penetration, you cannot just have a man shoving all the way because you're just wet at the entrance. That wetness needs to be serially introduced into the vaginal canal. And that's how women feel like they're very wet, excited at the beginning of sex, but in the middle of sex, they go dry. And then it's translated as, I may lose momentum, I may lose psych. You understand, yeah? Or it has never happened to you. So it happens.
Shocked.
So some women come and say, in the middle of sex, I just switch off. You don't switch off. It's just that you didn't take time to serially introduce that fluid that lubricates you. Yeah.
So the lesson we're learning here is
Bartholin.
Take your time.
Exactly, take your time. So now if we're talking about the Bartholin cyst, I'm sure the person who asked probably had an infection. Maybe that's why they asked. Yeah. So you see they release clear fluid, which is lubrication. But sometimes that canal, which releases now from the actual sac into the vagina, can get blocked. And the vagina is full of bacteria.
Yeah.
And so anything that is not flowing, fresh fluid, can get infected. And so then you have this collection of fluid getting infected. And so it can be filled with pus. And you will know a Bartholin's infection from even the way the woman stands, walks, or sits. They usually sit like this.
Like on the side.
Hivyo. Wanajulika. Yani hata wakiwa kwa consultation room, please let them skip line. Do not make them because it's so painful. And it can move from a Bartholin cyst to a Bartholin's. Now, when it has pus, it's called now a Bartholin's abscess. Yeah, so like a jipu. Yeah.
Oh.
Yeah, so now you just have to literally go in and drain the abscess, which is a procedure called a marsupialization. Kuna mambo mengi.
Nataka notebook. Niandike hizi points.
Sema tu Bartholin cyst iko infected ni Bartholin's abscess. It's so painful. It is so painful.
So what causes Bartholin cyst? Like aside from it blocking, like, why is it blocking?
Just your vaginal canal and the bacteria therein. It happens randomly. It has nothing to do with anything.
And are there women that are more susceptible to get the Bartholin cysts?
Yes, I would say if, for example, your lifestyle permits that most of the time you are at risk for other STIs, then also a Bartholin's abscess may be around the periphery of infections you're to have. Because things are constantly inflamed, things are not flowing and all that,
Interesting. So now when you drain it, does it go away completely?
No.
Is there like a dawa for it?
That's the thing. If you have a jipu here and I drain it, you can still get a jipu in the same place. True or false?
True.
Yeah, so there's a woman I've operated on 3 times. It keeps recurring over and over and over again. I know.
Wow. Crazy. Some things I didn't even know
existed. I know, lucky you. I couldn't even tell from your face.
I was super shocked, by the way. The Bartholin cyst thing really shocked me because I went on TikTok and I saw the videos and the images and I was like, this one I need an explanation from a Kenyan. I'll explain na Kiswahili. Nielewe.
Yeah.
Okay, so let's move on to the next question unless you have something more to say.
No.
Okay. Yes, another question. So I wanted to talk about, there's someone who asked about breast reduction and I wanted to talk about lumps.
Okay.
So I've mixed them into one question. Yes.
So we're talking breasts.
Yes, let's start with breast reduction. Like,
can we start with the opening statement that the breasts do not belong to a guy?
Thumbnail. The breasts don't belong to the gynecologist.
They belong to the surgeons.
Oh, okay.
But basically, when you're talking about, let's talk about the size. When you're talking about the size of a breast, it's a pretty subjective feel. What you feel is good enough, big enough for you is different from someone else. There are people who go increasing, other people feel like even what they have is little.
Yeah.
But when do we say medically that your breasts are a little bit on the what we call gigantomastia, okay?
Yes.
On the higher side or on the bigger side, when they start causing you problems in your health, in your posture, and in the way you sit and the way they carry on your frame. So basically, chronic backache, stooping position, you can barely get any fitting bras. These are people who go all the way to triple Ds. Just basically your quality of life. You can't move, you can't do sports because the weight of the breasts, okay? And so reduction usually would mean taking out some of the fatty tissues and basically, that's it. And then just leaving a more acceptable, more condoned size. On the other flip side, there are those who have smaller breasts and may want augmentation. And so augmentation here sometimes, most of the times actually, we tend towards the silicone cups. And so you go as per the cup that you want. Now, breast lumps, most of the time, it's important that I start with, most breast lumps are not cancerous. They're what we call benign. So when we say benign, benign means not towards cancer, just a swelling. It can be fatty swelling. It can be a cystic swelling. It can just be a fibrous swelling. Cystic means with fluid. Fatty means with fat. Fibrous means ni kama ile nyama ngumu inakaribia mfupa, ile tendon, something like
the
that.
one in the ear.
That. So something like that, okay? Now, they can grow. They are sometimes hormonally influenced. Around the time when a woman is breastfeeding, a lot of changes could occur in the breasts. So, for example, cysts, milk ducts, whatever. And so it's important to, first of all, get the diagnosis correct. So you first know, what am I dealing with? Most of the time, if they're tiny, they don't cause you pain. They don't cause any physical issues. You have done what we call I'll just abbreviate, FNAC, FNAC, meaning fine needle aspiration, meaning just stick a needle, pull out a few cells, test. Is it cancer? It's not cancer. Okay. Then let the person decide, is it really worth going to remove? If it's tiny, you leave it. If it's not bothering you, it's not cancerous, you leave it.
Yeah.
But if the FNAC now reveals that it's tending towards cancer, now that's when you may want to have a conversation towards now dealing with it properly.
Yeah. Well, first of all, thank you. Just realized in this talk show I've not said thank you once. So thank you for that, Dr. Swabra.
So pretty.
You too, babe.
Ni wale watu wanazanga tu alafu wanarudi soko immediately. Unaoga unarudi soko.
Where did the soko go? It has been there. So, maybe I have a very personal relationship with breast lumps because I read too much about them, having got one when I was so young. So now, I don't even know where to start. So now, I had spoken about it a bit on Instagram. So one thing I found out, like after I gave birth to Skylar, was that I got like a lot of milk and I realized one breast was now like really tiny. And then I went ahead to research and I'm like, could this have been because I had a breast lump? And then you'll correct me if I'm wrong, but the internet / AI taught me that when I had my breast lump taken out, they took out like fat, I don't know.
Fatty tissue, adipose tissue.
Yes. Basically where the milk is supposed to pass.
Yes.
So now that I got a baby and I'm supposed to have milk,
the pipe work is done.
The pipe work, some of it is not there, some of it is out. And that's why I had like a lot less milk and a very tiny breast. And by the way, it took me back to when I was in high school when I had one.
How is this breast so big? And
one is full of a kimango. And I felt like nobody actually has ever talked about it. I have never seen it anywhere on the internet that having a big breast lump taken out will affect.
Having major surgery. So I've had women who have suffered breast cancer before and have had a mastectomy. Mastectomy is removal of a breast, entire breast. And then she comes pregnant.
Ooh.
So then how is that mechanism? Because of course the nipple is out, everything is out. But even though the whole breast was not removed, so of course in that case we usually shut down the whole milk supply. We give drugs that do not even dare produce milk.
Yeah.
But there are those who part of a breast, like for example, if a lump was removed and if it was a big lump, then that means in the process of, especially in the hands of maybe not a careless surgeon, but yes, it could happen that as you're removing a big lump, that you remove and cause damage to the surrounding tissue. So the ducts are like tiny canals that build up to this pinpoint which is the nipple.
Yes.
So you have to imagine, kama zimetolewa all the time. So when you're producing milk, what happens? There's no canals.
Yeah.
You're only producing from a few channels. Exactly.
Yeah.
So that can be. You're even lucky. Sometimes it's not even about removing all of them. It could be that some channels are blocked, and so you have accumulation of milk on this other side, but they're not letting out to the nipple.
Yeah.
And so you get what we call now ducts that are inflamed, the ducts that are swollen with milk, which
And
then can
blocked.
lead to mastitis.
Oh my God, that thing is painful.
Very.
What? I don't know if I actually got it, but I went to hospital like thrice because I had some weird infection that can't be explained. And I was told it's because of
the breast.
Yes.
Exactly.
Yeah. So next question.
Shakipole.
I know. Wow. Women have too many
Pole.
issues
I
to be
know.
honest. Tutaongea hapa and we still won't finish.
Yeah.
Yeah, so another question was about hormonal imbalance and how to manage hormonal imbalance. First of all, what is hormonal imbalance?
Okay, I hate that word.
What is hormones that
Hormonal
are imbalanced?
imbalance, like what is imbalance?
Which
Where
word?
is the scale?
Which word do you like?
Oh, I don't like it. I do.
Yeah.
Money is a good word.
I'm
But
talking
anyway,
about hormonal imbalance. Focus.
because when you say imbalance, who is the weighing scale, and then now which hormones? So even as a gyna, I don't get to say hormonal imbalance. Sometimes it's a very loose language we use to explain certain concepts to the patients, and we try to simplify too much, but I feel like sometimes that's a dangerous ground because it's like now everything we say is hormonal imbalance. Anyway. Hormonal imbalance could be due to conditions like your thyroid is misbehaving, hypothyroidism, hypopituitarism, like there are so many hormones inside of you. They all talk to each other. Some could be higher than the normal levels, some could be lower than the normal levels. All that give you hormonal imbalance. We have this conversation most of the time when it comes to your periods as a woman.
Yes.
But you see now, I also can't just say the female hormones affect your period because even your pituitary gland, thyroid gland affect your period. You understand? So most of the time when you say loosely hormonal imbalance, I may have to first tease out which hormones depending on how you're presenting.
Yeah.
And that's how it looks like every time you go to a gyna, the bill is so high. It's because I refuse to imagine that I can just slap you with a contraception pill
just to mask whatever is going on
because
with
I'm
you.
not fixed. You understand? I'm just fixing the end product.
Yeah.
So I may have to tease out all these hormones to see who's at a normal level. And then there's also a concept where most people don't understand that the levels may actually read normal, but the functioning may be enhanced. So quantity is normal, but the quality and the functioning of a certain hormone is high. You understand? Good. So if I tease out and then I get to know that, okay, fine, your thyroid levels are high, hyperthyroidism becomes a diagnosis, I stop calling it hormonal imbalance, and then I give you medication for that. But yes, medication depends on the course as well, because I can't just give one thing to mask everything. Yeah.
I'm learning a lot.
I'm
learning a lot. So what basically hormonal imbalance is something that anyone can get according to like external factors.
Even men.
And tell us more about that. Even men can get hormonal
human beings are just functioning hormones. Like what makes you grow? Growth hormone. You understand? What is your stress hormone? Cortisol.
Yeah.
What is your adrenaline hormone? Like, adrenaline is a hormone, you understand?
Yes.
And so overproduction, underproduction affects the functioning of a body. So any imbalance, man or woman, can affect. Low testosterone levels will give me low sperm count, will give me, you understand, low libido. Even in women, we operate on our testosterone levels every time we're talking libido. I know you didn't know that. So basically, I know most women, every time we're talking hormonal imbalance, we take it to the periods, and of course, the commonest condition would be polycystic ovarian syndrome.
Yes.
I feel like we've talked about polycystic ovarian syndrome so much, and yes, it is one of the commonest manifestations of hormonal imbalance. But I would also like to say that there are so many in the textbook. There's PCOS, there's thyroid, there's prolactin, there's testosterone, there's estrogen, there's progesterone. There's a lot. There's a lot.
So what someone needs to do if they suspect that something is off, they should go to a doctor who is going to try and find the specific hormone that is imbalanced or has
and
a problem.
it's not even a gyna. Endocrinologist.
Endocrinologist. Word of the day.
Yes, endocrinologist. And so, depending on how you have come in, then I may start to tend towards what you're thinking. So it could be period, I'm headed towards. It could be, I'm just feeling tired, lethargy. I just feel like I want to sleep immediately. I wake up. I want to look at your thyroid. It could be that, hey, doc, me, I'm not breastfeeding. I don't have a child, but I'm removing milk in my breast.
Yeah.
I want to look at your prolactin levels, etc., etc., etc.
Interesting. We're learning a lot today. Okay, someone else asked about endometriosis and adenomyosis going undiagnosed. Should we have talked about that when we talked about
the periods? Yeah, sort of, but it's okay.
Yeah.
I call adenomyosis the ugly sister to endometriosis. Endometriosis has gotten this limelight. She's known about.
Yeah, people now know about it.
And then they love her. When I say they love her, it's like everybody now diagnoses endometriosis.
Yes.
But there's a silent, uglier side of endometriosis because most of the time the two come together. So adenomyosis is where, fine, let's start with endometriosis, where you find the endometrial layer happening outside of a endometrial cavity. You can have endometriosis in your diaphragm, in your lungs, and in your brain. Every time you're having a period down, you're also having a period in your chest and a period in your... I have a young girl who, every time she has a period, she has convulsions. 13 years old. Okay, so that is endometriosis. Then there's adenomyosis. Adenomyosis is where the actual musculature of your womb, like what literally bleeds every month, it's supposed to be a nice fleshy consistency. But when it changes consistency, becomes a bit fibrous and tough, you have to imagine that you're still contracting out a layer against such a tough tissue. So adenomyosis gives you pain. Actually, most of the dysmenorrhea we talked about, period pain, the minute you mention period pain, me, I'm not even thinking endometriosis. My diagnosis is always first adenomyosis. You understand, yeah?
Yeah.
So adenomyosis, fortunately or unfortunately, comes on a spectrum. So from barely there, very mild, to severely heavy adenomyosis. And there is no treatment to it. Treatment is tailored to the patient, and the eventual proper treatment, sorry to say, would be hysterectomy, where I take out your womb. So now you see, that's why we have to tailor the treatment to the patient. You have a young woman coming in like yourself, you're still in your reproductive age. I may not necessarily say, let's take out your womb.
Yeah.
So if it is not that bad, we give you painkillers. And that's how sometimes the gyna may look like they're just prescribing painkillers because I know what I'm treating cannot be taken care of. It's a consistency thing. Or if it is really, really that bad and something has to be done surgically, there's what we call excision, meaning I'm just going to debulk that you have most of adenomyosis on the back side, and it's even bulging out, like it's so tough, it's a thick tissue, it's an angry tissue, an angry womb, okay? You just go and shave off.
Yeah.
So literally we call it excision. So I'm taking out part of your wall of your womb, then patching things up, leaving you with a womb so that finish using it. But I know eventually I will come and take out the womb. So the proper treatment for adenomyosis is hysterectomy.
Yeah.
That has to be differentiated from endo.
Yeah.
Because not all endometriosis happens around your womb. So even me taking out your womb, what if you have endometriosis in your brain?
Oh, it goes even to the brain.
Yes. This young girl who convulses every time she has a period. So even though I take out her womb.
Yeah, because it occurs like outside the...
You understand?
Yeah.
May her soul rest in peace. Njambi Kaikai had lung endometriosis.
Yeah.
And so you can't take out her lungs. You understand? You can try to shave off as much of the endometriosis as you possibly can, but you can't take out the entire organ. So I would say adenomyosis easier to treat when you are allowed to treat. Endometriosis a bit harder to treat simply because it could be anywhere. Yeah. And most of the time they go together.
Where? Women. The real heroes of our time.
I'm telling you. Imagine the burden of having a womb. Is it a burden or is it a blessing?
I don't even know at this point.
I think we should have another sit down and talk about, like, have a debate. Have women on that side and women on this side, and we talk about, is it a burden or a blessing?
Yeah.
Because I feel like it could be the biggest blessing to carry a womb, but it could also be the biggest curse.
Yeah, I feel like it's too much. Even for me. How many times have I come to your office? Like, it's an emergency. Running to Dr. Swabra. So today I'm feeling like this. It's like, hey.
It is either bleeding, discharging, cramping, painful, bathing. Like, surely there's something happening with the womb. I know. And then there are men who are just chilling. That womb, what is womb? Define.
I can't even. And now we have our last question.
Tell me.
And you said we start light, we go
heavy.
Now tell us, you want to talk about cervical cancer. Early signs of cervical cancer.
Okay.
What is cervical cancer? Where does it occur? Okay, in the cervix.
Okay.
But yeah, everything cervical cancer.
So cervical cancer is where the cells on your cervix decide to go rogue. Okay, they're deciding they're not normal. They're now going towards cancer, and eventually they do get to cancer.
Yes.
I usually say cervical cancer is the most forgiving cancer. If you should do what you're supposed to do, it will rarely take you out. But if you ignore it, it will definitely take you out, and I'll explain. It is the only cancer that has what we call a precancerous stage. Like, the cells are just chilling, they were normal, and then they said, you know what, yeah, I feel like we can go and become cancer. But before we do, to chill kidogo tuone, tukete hapa katikati. Okay, so we're not normal and we're also not cancer.
Like that period when you're in the club and then there's music.
Exactly, so it's really dance, ama, kaende kasiende, apo.
Not funny.
Exactly. So that's what they do. And then they remain on the precancerous stage. And that precancerous stage also comes staged, meaning 1, 2, 3. Meaning, as you're on 1, you're near normal. As you're on 3, you're just a step away from now proper cancer.
Oh, I didn't know that.
Yes. And then now, now they decided now we are cancer, there's stage 1, stage 2, stage 3, and stage 4. And here's the thing. The whole point about cervical cancer and us talking about doing our pap smears and HPV DNA is to hopefully catch your cells. A lot can be done. Good treatment can be given, whether surgical, medical, radiotherapy, chemotherapy, at that point up to stage around 2A. But the minute it crosses over now 2B, stage 3, stage 4, when now the cancer has moved from your cervix into the surrounding organs, it becomes a bit difficult, to contain the cancer. So you may want to catch it before. So how do you catch it? Of course, pap smears. There's a lot of talk about pap smears, but the general rule is from 21 years up to 65, every 3 years. See, I did yours. When was the last time we did yours? When you had Skylar, so I usually like to tie it with your childbirth.
Is when I'm supposed to do
exactly, I usually like to tie it with your postpartum. That way it's very easy to remember. I when I had my baby.
Yeah.
Good. So every 3 years, I tell you you're good. That is a pap smear. There's another test which is called HPV DNA. I usually equate it to, instead of looking for a stolen TV, look for the thief that will otherwise steal the TV. So instead of me looking for cancer, I'm looking for the virus that will otherwise cause a cancer, which is HPV. Perfect. And so that gives you a more resting period between one test and the next because it's a bit precise. It gives you 5 years. So every 5 years, HPV DNA. And then the beauty about HPV DNA is the minute you do it and you find that you do not have a virus, even at your old self, you can still get the vaccine.
Oh.
Yeah.
What?
Yes. So the vaccine is not just a reserve for 8-year-olds, boys and girls. People forget boys. So boys and girls. So they are the carriers of HPV. Yes. So we give a vaccine to both boys and girls. But even as a grown woman who's already sexually active, if I do HPV DNA and you do not have a virus, I can still give you the vaccine. So what causes it? HPV. It has a precancerous and a cancerous stage, highly treatable, but also if it should spread out, quite a bit bad. And I feel like there are vaccines that you can get, and most of the time we have the two types, what we call Savarix and Gardasil. Potato, but one carries 4 strains, protects against 4 strains of the virus, while another protects against 2 strains of the virus. Yeah. Niambie, mbona unacheka?
Nimekumbuka kitu. So, ngoja acha tu nisidigress kwanza. But I wanted to ask, aside from the pap smear and basically the pap smear to check for the abnormal cells, is there something else that if someone notices in their body, they'll be like, hey, this is a red flag, let me get a pap smear?
The biggest singular symptom would be every time you have sex, you have painless bleeding. Hata inanga uchungu, haikuji kwa period, ni tu your cervix ikiguswa tu hivi tap, inamwaga damu. So spotting during coitus. But also aside, you can have discharge that is quite foul smelling. So every time we keep treating, and the infection and the diagnosis that keeps coming up, cervicitis, an infection of the cervix, you want to say, okay, fine, you know what, let's do our pap smear, okay? That's number 2. And then number 3, then you may have the surrounding organs manifesting, meaning the bladder, okay, you can have a bit of blockage in the ureters, the rectum behind, just the pelvic area, feeling of fullness, okay, pain during sex, because you have to imagine this cervix that is infected. You understand? Yeah. So such things.
Oh, wow.
And an actual wound.
So for context, this is the cervix.
That is the cervix, yes. And actually what you've just touched, the white thing, would be the signs of cervical cancer. Yeah.
I've spent too much time with you. Now I know, everything. So this is the fallopian tube.
Yes. Gynecologist Madge.
I know. But thank you so much. I don't think I have any other question. I was hoping someone was going to ask about contraceptives, but anyway.
We shall come to it. I'm always here. You're always here. The channel is here.
Yeah.
Are you going to tell them to subscribe? Because this is a beautiful space.
Subscribe.
Yes. And share with other women.
Please share widely this video. People actually need this video. You just don't know.
Yes.
But people need this information. This information is not out there as you think it is. You know, most of us are privileged. For example, I am very privileged right now because I'm sitting.
I'm privileged to have her friendship.
I know, she has taken time out of her schedule to sit down with me. I feel like that's very commendable and very kind. It's very kind of you. Thank you so much. Mind you, hata silipi.
Thank you for having me. Nilajawambia kitoka.
Silipi. I'm just paying with acts of kindness. Next time I'll come here with a coffee, and cake, hugs here and there. I'll hold your baby. But thank you guys so much for joining us in this sit down with Madge. Is that what you're calling it? I don't know. We'll see. Sawa. Thank you guys.
And on to the next.
Bye.
Bye.